I'm Kristen Bane. I'm a senior here at Presbyterian College, and I'm going to be presenting the research I did throughout this semester under Dr. Wetzel on anterior cruciate ligament injuries in female athletes. Here's an overview of what I will be discussing in my presentation today. First, in the introduction, I will review the functional anatomy of the knee, then move on to some background information on ACL tears, and lastly discuss the mechanisms of injury and symptoms of an ACL tear. Next, I will discuss the purpose of my research as well as my hypothesis, and then I will go into the methods and results of the research, and then finally the conclusion and end with some future research opportunities. To begin the review of the functional anatomy of the knee, I dissected a deer leg. While a deer leg is similar enough to the human leg for the purpose of this research, they are categorized into different walking postures or stances. Deers are unguligrade, which means they walk using the tips of their toes. They are joined with species like horses. Humans are plantigrade, so their walking involves placing their entire foot structure on the ground. And there are also species of animals that are digitigrade, which means they walk with most of the length of their digits making contact with the ground, but not the soles of their feet. Examples of digitigrade animals would be dogs and cats. Unguligrade animals like deer have very similar leg anatomy to that of the plantigrade humans. I dissected and labeled some of the major groups of muscles that are used in the movement of the knee in this diagram. And then also before moving on, I wanted to take a moment to thank Dr. Gordon for getting this deer leg for my research. To continue my review of the functional anatomy, I used clay modeling to complete a physical reconstruction of the knee. In the anterior view, I wanted to emphasize the sartorius muscle, as well as the four quadricep muscles, the rectus femoris, the vastus medialis, the vastus lateralis, as well as the not pictured vastus intermedius, which lays deep to the rectus femoris. These muscles are all work in the extension or straightening of the distal leg or calf area at the knee. The flexion or bending motion is produced by the biceps femoris, which you have over here in the posterior view. You have the long head as well as the short head. And then the semitendinosus, which is right here in the center, and the semimembranous muscle. The popliteus down here facilitates the flexion movement by unlocking the fully extended knee joint. And then slight rotation of the knee in the flexion position is allowed for by the biceps femoris, semitendinosus, the gracilis, as well as the sartorius muscles. I continued to use clay modeling to illustrate the anatomy of the ligaments of the knee. Ligaments are fibrous connective tissues that connect bone to bone. They function to support, stabilize, and limit movement in the knee joint. The main focus of this presentation is the ACL, or the anterior cruciate ligament, which is shown right here in the clay modeling figure, and then right here in the other figure. The ACL attaches to the medial wall of the lateral femoral condyle, as well as the middle of the intercondylar area of the tibia. It specifically functions to prevent the tibia from sliding out in front of the femur, also called anterior translation of the tibia, and it also provides some stability in the knee during rotation. This image is from the deer knee dissection that I spoke of earlier, and it shows the ACL. It was really interesting to me to be able to hold the femur and the tibia and put different stresses on the knee and see how the ACL handled these different stresses. So now to move into some background information, there are approximately 100,000 to 200,000 ACL tears in the United States each year. ACL tears are usually season-ending injuries for athletes because rehabilitation to the level of return to play usually takes about 6 to 9 months. ACL tears can be due to a contact injury, like a direct blow to the knee that causes hyperextension of the knee, or valgus stress, which is when it's bending inward. About 70% of ACL injuries are non-contact injuries. Non-contact injuries occur during a quick change of direction, slowing down, or landing wrong from a jump. Female athletes are 2 to 10 times more likely than males to sustain an ACL tear. The increased risk depends on the sport that is being played, with female soccer players being 3 to 5 times more likely, and female basketball players being 2 to 7 times more likely to tear their ACL than their male counterparts. As I was discussing on the previous slide, there are different maneuvers that can cause an ACL injury. Pictured on the right is an Acl Avulsion fracture, which involves the separation of the tibial attachment of the ACL. These avulsion fractures are typically caused by forceful hyperextension of the knee or by a direct blow over the distal end of the femur with the knee flexed. Avulsion fractures are less common, with tears more frequently occurring throughout the ACL itself, as pictured on the left. The most common movement associated with tearing ACLs is a cut and plant movement. This movement is used in quick changes of direction, which is seen in a lot of competitive sports, such as the high-risk soccer and basketball. Some common symptoms when a person tears their ACL is an audible pop that's heard. That occurs about 70% of the time, and it's caused by the sudden release in pressure when the ligament tears. There is also usually severe pain at the time of the tear and rapid swelling. However, the pain subsides after some time, but you're left with a restricted range of motion and an unstable feeling, or feeling like your knee is about to give out. When diagnosing a torn ACL, you will first want to start as non-invasive as possible. There are 3 different examinations that can be done in the field. They're usually done by an athletic trainer or a physical therapist. One of these tests is the Lockman's test. It's a passive accessory movement test that is performed to determine the integrity of the knee joint and the ACL. To perform this test, have the patient lay down and flex the knee 20 to 30 degrees while the heel rests on the ground. Grasp the femur and the lower leg at the proximal tibia and tug forward. This should produce a firm endpoint. If it does not, and there is anterior translation of the tibia, then the test would be positive and the ACL would need to be assessed further. The next step would be to utilize some sort of non-invasive imaging. This may be an X-ray to rule out a bone fracture. However, more commonly, it would be an MRI to show the extent of the ACL injury and assess if there is damage to any other tissues in the knee. So here are some examples of what a normal ACL would look like. As you can see, both the attachment, and then moving on, here's the incomplete ACL tear, right here, where you don't see the attachment to the femur, and then the complete ACL tear where you cannot really see it connected in any sort of fashion that it should be. The focus of this experiment is the effect of hormones on collagen. So I wanted to provide some additional background information regarding what collagen actually is. Collagen fibers are the basic building blocks of ligaments. They're very strong and flexible, which means they're resistant to damage from pulling or compressing stresses. As shown in the figure, they're arranged in bundles, and the primary bundle is of specific interest in this study. And we're also going to be looking at the fibrils and how their spacing affects the width of the bundles. This is a histology slide of a muscle to tendon junction with the higher magnification showing the collagen bundles. You can really see the separation of each bundle, and then the purple spots are the nuclei and the area surrounding them are the fibroblasts. So now I'd like to move on into the purpose of my research and my hypothesis. The purpose of my research this semester was to explore the physiological basis of why female athletes are more susceptible to non-contact ACL tears, specifically assessing the possible role that estrogen plays in putting this population at a higher risk. Then I hypothesized that estrogen would weaken the collagen and ligaments by creating larger gaps between and within the individual bundles in comparison to the control and the testosterone treatment. So I also wanted to further explain the terms that I'm going to be using in my methods. So I'm going to be using estradiol, and then I also wanted to explain the type of testosterone that I'm going to be using. So estrogen is one of the female sex hormones. There are three main types of estrogen. Estradiol, which is the most common type of estrogen produced during a woman's reproductive years. Estriol, which is the main estrogen produced during pregnancy. And then estrone, which is the only estrogen your body makes after menopause. In this study, I used estradiol because the focus group is female athletes, which generally speaking is women in their reproductive years. Estradiol is present in both men and women. In women, it is produced primarily in the ovaries, and in men, it is produced primarily in the testes, but obviously at much lower levels. Androgens are the group of sex hormones in men, with testosterone being one of the major sex hormones. There are two types of testosterone, free testosterone and bound testosterone. 98% of the testosterone in males is called bound testosterone because it binds to other molecules known as sex hormone binding globulin, or albumin, which is a type of blood protein. On the other hand, the rest of your testosterone is free testosterone, which isn't attached to any other molecules and is typically used up by the body. For the purpose of this study, we used free testosterone. So now I'll move into my methods. I used the PCL from the deer knee that I was previously talking about. I used the PCL instead of the ACL because I had already extracted the ACL. So I just used what was left, which was the PCL. And to ensure that it would take up the hormones that it was being exposed to, I rehydrated it in physiological saline overnight. I then sliced the PCL into 3 equal pieces. One piece was exposed to estradiol for 2 hours. One was exposed to testosterone for 2 hours, and then the control was exposed to saline again for 2 hours. They were all then rinsed with a 10% buffer formalin for 30 minutes. And then we dehydrated the samples in ethanol at a 30%, 50%, 70%, and 90% for 30 minutes each, and then 2 times in absolute ethanol for 30 minutes each. So then we used a dissection microscope to tease collagen bundles apart, and then we actually did 2 different things. We took a couple of those teased collagen bundles and we added multi-stain to make them show up more, rinsed them in alcohol to get the excess multi-stain off, and then we viewed those under the light microscope. And then we took some other collagen bundles that were teased apart, chemically dried them in HMDS twice, and then we mounted them on a stub, and then we viewed them under the scanning electron microscope. So these are the results of the light microscopy. Over here on the left, we have the estradiol, at the top, the saline, and then at the bottom, the testosterone. As you can see, the saline and the testosterone look pretty similar. However, the estradiol has some gaps present, and you can see where these bundles were once one over here in the corner, and how the fibrils are looser and not as compact as in the testosterone and the saline images. And here we have the results of the electron microscopy. We have estradiol here on the left again, saline at the top, and testosterone at the bottom. These structures are the bundles. The testosterone one is a little more difficult to see, but this is the bundle right here. And then in the estradiol one, here's the bundle. So we analyzed multiple sections of bundles, and overall we were finding a consistency of about 200 microns as the width. So for the saline and the testosterone, this was true almost all around where we looked. However, in the estradiol, again, there were gaps present, which increased the width from the 200 microns, which it probably would have been without the gaps present. So in conclusion, one possible explanation for the increased risk of non-contact ACL tears in female athletes is the role estrogen plays in the weakening of collagen. Although it would have to be confirmed with further trials, In this study, estrogen seems to draw apart the collagen fibrils, creating gaps in the collagen bundles and thus making the bundles greater in width. The ACL would then be easier to tear as the bundles are more spread out, so you would be tearing individual fibrils or small groups of fibrils rather than one tighter bundle, as shown in the control and the testosterone treatment. When I was discussing these results with Dr. Wetzel, he used the analogy of tearing a phone book in half, and ripping it when it's closed and all the pages are together is extremely hard. However, if you try to rip it in smaller groups of pages, it becomes much easier to tear, which is essentially what we think is happening here with the ACL. Again, we would have to do further trials to confirm these findings, but this is a starting point for some future research. And then lastly, I wanted to put some future research opportunities that are of interest to me out there to assess the possible hormonal therapies to lower the risk of an ACL tear, to analyze the effect of testosterone on a partially torn ACL as a possible non-surgical treatment option, and then risk assessment of ACL tears before, during, and after puberty in females and males. And then here are all the references that I used in my presentation. And I would also like to say thank you to Dr. Wetzel for all his help this semester in helping me complete this research.